Good morning, everybody. Welcome. My name is Robert Stevens. I'm from Johns Hopkins University. And it's really my great pleasure to open and chair this session devoted to Rehabilitation Starts in the ICU. This is a hugely important topic which is going to gain more and more importance over time. And we have an extremely distinguished panel of speakers today to talk to us about rehabilitation. The first one is Dr. Kate Klein from Cleveland Clinic, and the title of her talk is Effects of Early Progressive Mobility in the ICU. Just regarding one housekeeping thing regarding questions, I know that you're probably burning with questions during each talk, but I would ask the people to wait until the very end of the three talks, and then we'll bring the speakers up here and we'll respond to all the questions. This way we can get through the actual talk sufficiently. So thank you very much. Dr. Klein.
Good morning, everyone. Thank you to the Society for having me speak about a subject that's really important and, of course, part of the A through F bundle that is an area that we've been working on a lot at Cleveland Clinic. So I want to share with you some of the work that we've been doing. Disclosures are just Hill-Rom Company. They were big supporters of our research. So what we'll be looking at is a little bit about the historical perspective of mobilizing critically ill patients, and then just a very brief review of the evidence. And then a piece that I'd like to talk a bit about is safe patient handling and how mobility with safe patient handling go hand in hand. You can't have one without the other. And then also sharing some components of building and sustaining a mobility program, and then some highlights on the impact that early progressive mobility has on the patient experience. So we can't get away from this equation. We're all seeking to improve the value of the care that we provide, and if we can improve the outcomes and with that reduce the cost, we can have much better value to the care that we provide. And how do we do that? This is a perfect example of the A through F bundle. Providing each component of that provides really solid care to the patient. And all together, as Dr. Ely spoke about yesterday, all of those, all combined, offers the patient some really valuable care to help liberate them from the intensive care. So immobility impacts nearly every organ system, from the skin to every organ. Musculoskeletal, we lose in the first 2 days, we can lose up to 15% of our muscle mass, or 50% after 2 weeks. It's tremendous. Looking back, this is back in 1975. Okay, they studied early progressive mobility at Geisinger, and here you have a gentleman up on a ventilator being mobilized. Today, we strive to do that again. So I looked at this, and I was reading through, if such patients are confined to bed or chair simply because they are tied to the respirator, are they necessarily predisposed to muscular and skeletal wasting, thromboemboli, decubiti, et cetera? So what they found in their work, back then in 1975, early ambulation is clinically useful, patients accept it, weaning has been facilitated and hastened, problems of prolonged bed and chair rest are minimized. So this isn't a new concept, and I think if you talk to any seasoned nurse, one that's been practicing for the last 20 to 30 years, we used to mobilize our patients. So I ask, what is it that sentenced our patients back to bed? And talking to nurses and going through the literature and diving into this question, what is it? Nursing workload, okay? The documentation is really overwhelming our nurses. Procedures, fear of the indwelling catheter. Our patients are sicker and sicker these days, so their indwelling catheters, be it in the neuro ICU, we worry about the ventriculostomy, central lines, et cetera. Lack of a structured multidisciplinary mobility program. Lack of clear safety parameters. Is it safe for the patient to get out of bed? Okay. Inadequate equipment, and just not the culture of mobility seems to have dwindled away. So can we put our patients back into focus? I think that we can. Absolutely. Again, and through this bundle, this is such a perfect bundle of care to provide for our patients. And as Dr. Ely also said yesterday, in digging deep down into our patients that are in chaos and pulling them out and liberating them from all the things that we've had to do to keep them safe. The literature is full of work that's been done to show that this, for the patient, mobilizing them is safe, it's feasible, and improves outcomes. Okay, and for the hospital, decreased length of stay, never events, and also readmissions. This is a nice review that was just done in 2015 for both the adult and the pediatric ICU patients. We're also getting pretty creative. So cycle ergometry, if a patient can't get out of bed, putting a stationary bike at the end of the bed so that they can cycle. You know, it's something that's familiar to the patient. It's part of normalizing. I mean, how great would it be to ride a bike in an ICU? It's perfect. And then muscle stimulation. There's a couple of system reviews out there showing that muscle stimulation can improve the muscle wasting. Okay, and then one of the things that we still have a lot of work to do is in defining the safe and effective mobility dose. Okay, we've done walking distances, time, that kind of thing, but we're getting pretty creative with looking at accelerometry, and then also these human motion tracking. There's these miniature inertia sensors, so that we can really measure how much does it take to get those kinds of outcomes. Okay. Now I'm going to break. I work in a neuro ICU at Cleveland Clinic, and so it was really interesting to me 7 years ago when none of our patients were being mobilized, and we didn't have the equipment for that either. So I thought I must be missing something. So I'm trying my hardest to pull that patient population into the mobility as well as the A through F bundle, because our patients that suffer a stroke stand to be very disabled, incredibly disabled, so that they will need 24/7 care even. So I always question, is there more that we can do to optimize their rehab potential? Okay? Can we get them moving more than we are? Or can we do something early on to help them? Neurorehabilitation, what this looks like is optimizing and normalizing the environment. Okay, for improving the cognitive and motor skills. It's engaging patients in normal activities, okay, getting them up. It's not normal to be lying in bed. It's normal to get up and putting a comb in their hair, a toothbrush in their hand. Okay, building their strength and their speed to be able to do those activities. Okay, and there are parts of the brain that can be stimulated with this normalcy in their activities. And that is the reward system, the basal ganglia, and then along with the memory regions in the frontal lobe for increasing willingness to engage, acquisition, retention, and retrieval of information, as well as, and very importantly, just instilling hope. It's quite something when you get that, when the patient's brain begins to clear, and then you begin to progress them, their mobilization out of bed, into a chair, and even out of their room. It's really remarkable to watch their expression. And there's also this concept of neuroplasticity, right? Finding new ways, finding new pathways. So it's engaging the non-injured area of the brain to kind of take over and find new ways for the brain to work. So there are plenty of people there are several people that are functioning just fine with one hemisphere. It's possible, but it's only possible if they go through really strict and aggressive rehabilitation. Functional MRIs show that this is heightened within 3 days of injuries, which underscores that it's really important to do this early. But what is too early for patients with neurologic injury? And this is a review that was done that looks at a bunch of papers, and again, clear benefit to the mobilization, but not clear how early it is. And that's something that we need to take into consideration, because when the brain is injured, there's autoregulation that's disrupted as well. So we have to be very careful about mobilizing our patients, that if they can't, when we sit our patients up, if they can't perfuse their brain because of that posture change, without increasing their blood pressure, then we stand to increase the size of the injured area, just because they can't regulate that posture change. Okay, and the AVERT trial certainly showed us this, and we hypothesized that that's what's happened. We don't know for absolute sure, but it certainly makes sense. And even the AVERT group, even though their dose of they were able to mobilize their patients early and for a longer period of time, look what happened. In the usual care, here you show our patients' outcomes were better. Their modified Rankin score was a 2. 22 patients reached a modified Rankin score of 2 versus the treatment group. So that brings us pause as to, wow, do we really need to think about, we've changed our practice that we're not getting patients up for 24, until after 24 hours now because of this study. And then this is 2 studies that were done at Cleveland Clinic along with Shands, Florida, looking at solely at patients with neurologic injury. And again, designs are pretty much the same. We had incredible results with mobilizing our patients. It's possible to get our patients up. We had a 2-fold increase in the number of patients that were getting up. Dr. Titzworth and his crew had a 300% increase in mobilizing their patient. And then our clinical outcomes, again, just really significant. So this patient population really stands to benefit just as much as all the other ICUs. We did some work on how patients felt. Using a brief symptom inventory, depression, anxiety, and hostility scores were markedly reduced. And then we looked at cost, when there was a 30% reduction in overall cost. So it was really hard this really drove us into translating this into practice, which we did, and we developed something called the Mobility with Safe Patient Handling program. This is a multidisciplinary program. It involves the entire team, and we talked to Brenda Pun yesterday, talked about the importance of teamwork and engaging all members of the team in this. And this requires that everybody be on board. It's what helps to change the culture and the thinking around this. And then what this program does is it starts in the ICU, or if the patient is admitted to the ICU, or any other area of the hospital. So this truly is a program that's applied throughout the care continuum. Okay, so if you're giving your patient treatment in the ICU, it's really important that program is also, the rest of the hospital is exposed to it as well, right? So this paper speaks to that they looked at patients in the ICU transitioning, and after transitioning out of the ICU, 16 hours. It took 16 hours for patients to regain their ICU highest level of mobility when they were up in a chair, and then 7 hours to regain ambulation. So that really speaks to how important it is that not only your unit, but your entire care continuum. So the piece that I wanted to speak to you about is the nurses. Like if you have this program to mobilize, you have to figure out how are we going to do this. It's not okay to say, well, we'll just have the nurses lift the patients. They too need to be safe in this process. So that brings in the safe patient handling piece of this, because nurses in an 8-hour day can lift up to 1.8 tons, and cumulative musculoskeletal injury is a problem. It's one of the leading most costly occupational health problems, and it's really. And our nurses are suffering with the amount of mobility, and they want to move patients, but it's up to us to provide them with the equipment that they need. OSHA, this is also what's really exciting about this is they put into legislation a law to make this making a no manual lift law, not just at the outpatient setting, but also in the acute setting as well. So solutions to the problem these are the safe patient handling equipment, starting from the bed, having devices that help to reduce the friction, along with helping with the lifting, so that nobody's lifting. This is some of our crew at the Cleveland Clinic, so, okay. So our program begins with safety. Is our patient safe to get out of bed? Okay, through the American Association of Critical Care Nurses, they have a Move On tool, and they gave us permission to add O for other and N for neurologic. So having some safety parameters. This is a guide for the nurses to decide, is my patient safe to get out of bed? And taking care of pain. Mobilizing, if they haven't mobilized for a while, it can be very painful. Edema can be very painful. Okay. And then we've also created something called an inpatient functional mobility score, so that we can objectively measure how much assistance that they need with each activity or throughout the day. And this is a wonderful way to celebrate too, an objective way of celebrating their progress each day. Okay, and then once we've decided the safety, we know what their score is, we know what their level is, let's move. Okay. There are roles for each clinician, there's activities to achieve, and then there's the recommended equipment as well. And this all is the mobility with safe patient handling is a real guide for all of our nurses in every institution on how to mobilize patients safely. And then these are a variety of outcomes that, with this program can be looked at. Efficiency, effectiveness, impact of the caregiver, patient experience, and how do we plan to be successful at this? And we've got a variety of ways of team building or team communication, and then also along with orientation, because we've certainly had some of this equipment, but it's not being used. It's collecting dust. So having a structured program in place to apply to their practice. And certainly mobility with safe patient handling care path, it's linked in the future. We're looking at linking the inpatient along with the outpatient as well. And I'd like to finish off just with the impact on the patient experience. And I have a very short video that I'd like to share with you that sums a lot of this up, both the mobility and the safe patient handling piece of this.
We had a softball tournament that weekend. When I woke up in the morning, I noticed my fingers were a little numb. My feet kind of tingled like they had fallen asleep. I just kind of brushed it off as it'll go away as I get through the day and get moving. When I woke up the next morning, my entire body was numb. I couldn't hardly pick my head up off a pillow. I couldn't really talk. Even my respiratory system was slowing down. And that's when I told her that I'm getting worse, I'm not getting better. It started to scare me. At that point, I decided it was best to just get to the closest hospital.
And they had him whisked off so quickly and diagnosed that it was not a stroke or a heart attack, but we did not know what it was. And then towards the evening, they said, we think you should transfer to a larger hospital because we don't have the neurologist here to treat you.
My oxygen levels dropped severely. My blood pressure dropped severely, which put me into a critical state by the time I got to Cleveland Clinic.
I knew when they took him into the ICU that I saw him struggle. I saw him struggle. So I didn't know. I didn't know from there. And the neurologist came into the waiting room and she told me that it was Guillain-Barré syndrome. And it was a virus, and that it had attacked his respiratory system.
This is an autoimmune process that affects the peripheral nerves and affects the covering of the nerves, so that patients are neurologically devastated. He was completely quadriplegic. He could not move any of his arms or legs, and he was so weak from a respiratory standpoint, he had to be intubated and be placed on a breathing machine that was providing all of his respiratory function.
There is a treatment for Guillain-Barré, and people generally do recover from this, but for Brent, it was really incredibly uncertain.
I believe I was intubated for 9 days.
It's very crucial during that time that patients are so incapacitated that they need to be mobilized, they need to keep moving. There are all kinds of medical complications that can occur just from being in bed.
Bed rest really affects every body system negatively, and by getting the patient out of bed, we can make a huge impact. Probably the most incredible is it decreases depression and it decreases delirium in our patients, which is huge.
We know that for every day that you're in bed, it's 3 days of rehabilitation because you deconditioned that quickly. One of the interventions that we're really working on here is to get patients up and out of bed and moving and normalizing their day as soon as possible. For Brent, we felt it was safe for him to get out of bed. We approached him and said just that, how would you like to get out of bed? And he sort of had this bright look on his face, but then he became very concerned.
They put him in this sling underneath of him and lifted him up out of bed and put him in a chair.
It's a lift mechanism that comes down. It has a bar. We put a very strong sling underneath him that connects to the lift, and then we lift him up. And it's really important to describe all of that to patients so that they understand what's about to happen to them.
I felt so safe and secure seeing him being lifted and put into a chair, and I realized how important it is to be upright, to breathe, and how quickly he got so much better.
It was actually something I look forward to, getting out of bed, sitting in a chair.
You could just see the improvement day by day. It was leaps and bounds.
That's how quick things happen from my first chair trip to ventilator off to going to rooftop. That's how quick it all happened.
Is Mr. Boyle a wonderful success story? Yes, he is. But every patient is a candidate for the kind of care that this care path is prescribing, because we know that this is the right care to provide to every patient, every family. And it's the right thing to do for every caregiver, not only to help them have the tools to mobilize our patients, but to do so safely. We've had caregivers say, wow, I knew that mobilizing my patient was the right thing to do, and I got to provide the type of care that I wanted to provide. I went home today feeling like I did a good job for my patient.
It's probably one of the largest rewards that you can have when working in this profession. I can think of no better case for this.
I am 100% advocate for this mobility program because it made the difference. Just feeling safe and secure that nothing was going to happen. I was in that brief moment of what will I do without him, and then was quickly reassured that he was so well taken care of that everything was going to be all right. The fear quickly left me, and I had such confidence of where we were at.
When you go from a period where you think that life's over to life's been changed forever to life's normal again.
Thank you.
So that was an awesome video clip. In fact, it was made by, I think, Previn George, one of my fellows at Johns Hopkins. I think he had a part in it. In any case, I'm really, really happy to introduce the next speaker. It's Dr. Wesley Ely. Dr. Ely will be talking about cognitive therapy for enhancing recovery in the ICU.
Well, that's a hard act to follow. That was a beautiful video, Kate. And I'll tell you, Kate Klein and Heidi Engel, who is going to go after me, are two incredibly powerful, intelligent, and very passionate women in the field of medicine, a nurse practitioner and a physical therapist. And I kind of know when it's right for me to get out of the way and let them go. So I'm going to talk just briefly to you and give you a very short form of a story about the brain, because the brain is a big part of PICS, the post-intensive care syndrome. But I really want us to be able to focus on this huge aspect of post-intensive care disability, which could be thwarted, could be improved, rather, by early mobility. So I'm going to be relatively brief. It'll create a lot of time for us to have a Q&A focused on what Kate and Heidi are presenting to you, if you don't mind. The main take-home message that I've been asked to speak about the neck up part of post-ICU disability. And what I'm going to do is describe for you very briefly the public health problem to make sure that everybody in the room knows what the data are about the brain post-ICU. And then I'm going to tell you so that everybody, when they walk out of the room, will be up to date on where we are in the course of research in this area. And then I'm going to leave you with a thought for you that what is the relevance of this in your life as a clinician right now, even though we don't have all the answers yet about how to rehab the brain from what I refer to as micro trauma rather than macro trauma. Kate Klein was talking about neuro-ICU patients in terms of, for example, head trauma, massive strokes, et cetera. We have millions and millions of people around the world who are dealing not with macro trauma that you would see on a CT scan or an MRI, but rather who have micro trauma in the way of neuronal apoptosis from loss of neurons in the billions that occurs during routine critical care on a ventilator, on pressors, with sepsis and or whatever other garden variety illness gets them into the ICU. And the critical thing for us to realize is that this is occurring not just in one of our ICUs, it's occurring in all of our ICUs. I like to use the example of noses. Noses come in all different shapes, sizes, and colors, but they all work the same way. And the problem about post-ICU disability is not just in the medical ICU or the burn, or it's in every ICU that you care for patients in. And this issue of, I've heard people say, well, in the neuro ICU, we have bigger fish to fry, bigger problems. We've got a stroke, we've got an intracranial hemorrhage. But do you not think that those patients are also then at higher risk for the neuronal apoptosis that the MICU patients get? They absolutely are, because they have less margin for error. They are already lower on the brain totem pole, so any further injury is going to give them a bigger post-ICU deficit. So that's the first point I want to make, is that wherever ICU you work in, this issue of acquired brain disease during the ICU is relevant to you. The best data we have in the non-macro trauma arena would be the New England Journal data from the brain ICU study that showed that upwards of 30%, 1 in 3, and depending on the patient population, over 1.5 of our patients end up with a moderate to severe cognitive impairment that looks a lot like a dementia. And the deficits primarily are memory and executive dysfunction. With that in mind, we set out about 10 years ago to create a research program that could do something for the brain after the ICU. And I say this as a complement to the mobility programs that Heidi and Kate will tell you about. So obviously we need to do what we can neck down to get the patient's body back, and that will help the brain. When you exercise, your brain snaps better, you get more connections going, and the brain is stimulated to recover itself. That's why, as your nurse said, early mobility reduces delirium, for example. We know that it cuts delirium in half. So, in addition to that, however, why not, if you were trying to rehab the bicep, you would do physical exercises for the arm. If you want to rehab the brain, why not do cognitive exercises for the brain, right? So we got a grant about 10 years ago from the American Federation of Aging Research for $500,000. That's not a lot of money. A lot of our grants are more 5 to 10 million or more, but this $500,000 we took, and we designed the first cognitive rehab program for post-MICU patients. And what we did, if you look up here for just a second, take the ICU experience, let's call that phase 1, admission, discharge. Then let's take the second phase, post-ICU, let's call that phase 2 for purposes of our conversation. What we did was we took people at the end of their hospitalization, at the end of phase 1, we screened them for cognitive deficits. These are all people who had been in the medical ICU, who had been on a ventilator and or in shock. One of those two major illness barometers had to be present. So either enough respiratory failure to land you on a ventilator or enough hypotension and shock to land you on vasopressors. We then enrolled these patients in what we consider absolutely a pilot investigation. You can't do a real phase 3 investigation for $500,000. But we enrolled 20 patients, and we randomized these patients. That's not the exact number, but roughly 10 to 15 patients per group. And so at the end of the hospitalization, we then took half of the patients and let them go home for usual care, and we took the other half and we put them through a cognitive rehabilitation program. Not physical, just cognitive. They could get whatever physical they were going to get, they got routinely. It evened out across the randomization. What we found was at the end of 12 weeks of the cognitive rehab program, I'm going to tell you what it was, the people, even in that small group, this small pilot study, we saw that the 15 the 15 patients in the cognitive rehab group had significantly improved cognition in relationship to their baseline post-phase 1, post-illness cognitive function. At the end of the hospitalization, when we randomized them, they were the same. And then 12 weeks later, they were different. So it sent a signal to us that maybe this brain is get-backable. Maybe some of this can be recuperated. And so the patient would have then a better long-term cognitive function. With that, we had a second research project called the ACT ICU. That first project was published in Critical Care Medicine. And Jim Jackson is the first author. If you email me at wes.ely@vanderbilt.edu, I can send you any of these PDFs that I'm about to talk about. The next study, we decided, Nate Brummel, who's at Vanderbilt and one of my mentees, decided he wanted to study phase 1 and phase 2 cognitive rehabilitation. So we did. We had people in the ICU doing Sudoku and Scrabble on the ventilator. They were exercising their brain in there. We allowed it to be tailored to the person. So if it was a math professor, we would do Sudoku. If it was a literature professor, we would do Scrabble. And I'm simplifying this, but we would allow them to gravitate to whatever they enjoyed the most. And we quantitated how much time they spent doing this. And then we also put them through second phase 2, the same cognitive rehab that we had used in the first study. Now, the cognitive rehab program we chose at the time was called GMT, or Goal Management Training. It's a very famous cognitive rehab program that was invented by some Scots and some Canadians, and we partnered with them to put this into play. The thing about the GMT, though, is that it's clunky. It's clunky and it's old. So I'm about to tell you where we went from there. But before I do, the GMT was on paper. It was around tables. It was homework for them to do over 12 weeks. It was aggressive, but it was something that they enjoyed doing. They had fun with it. A lot of it was tailored towards executive dysfunction rehabilitation, because these are people who wanted to go back to work. They couldn't get back to work because their executive dysfunction, their executive function was in the trash can, and so they were getting fired from their jobs. There was a lot of heartache in their lives, and we were trying to get that executive function back for them. So GMT was mainly focused around executive function and memory. And one of the ways to explain what we were trying to do is outlined by Daniel Kahneman in his famous book, Thinking Fast and Slow. If you haven't read that book, go to the bookstore and get it. It's absolutely fascinating. He won the Nobel Prize for economics because of the way that he thinks through the way the brain works. But Thinking Fast and Slow takes you through the odyssey of the discovery process that Kahneman went through as a Nobel laureate psychologist. And the simplest example I can tell you is if you're driving a car, and your kids are in the back and you're trying to turn the radio, you can do all of that, driving the car, radio, somewhat distracted, but you can get by okay. We all have done that before. That's thinking fast. That's using system 1 in your brain, according to Kahneman. The system 2 in the brain requires you to think slowly. So if you are doing all that and then you have to turn left into traffic, think about oncoming traffic. You would have to say, hey, shut up, stop, think, look, what's going on with the cars? Now you're using a different system in your brain. You're not on autopilot anymore. You now have to stop, think, and really make some critical decisions so you don't get into a wreck when you turn left into traffic. What we think is happening is that ICU patients are losing their system 2. It's the override, it's the protector of system 1. It's what stops you from hurting yourself. And so in the ICU, if patients are losing their system 2, that executive control modulation, then we need to get that back. And we think it's because of damage to cells in the frontal lobe and in the hippocampus. And we have MRI studies and CT scans to show that that is where the greatest atrophy occurs in the brain. So anyway, GMT seemed to have worked. It got us started, but it was too clunky. So now where we are, and I'm bringing this talk to a close right now, and then I'll give you your take-home of what I think this means for you in 2017, and then we'll get on to Heidi. Now what we're doing is we've gone way beyond the clunky paperwork, and we're using computers, iPads, and games. And the way we made that transition was that 2 major neuroscientists in the world, a guy named Mike Merzenich and a guy named Adam Ghazali, both from UCSF. I don't know if you ever met them before, but they're amazing people. The first time I got Mike Merzenich on the phone, I was in Jerusalem running on a run. I was listening to a book called The Brain That Changes Itself, which is a fabulous book. If you've not read that one either, that's 2 book recommendations for you. The name, The Brain That Changes Itself, is by Norman Doidge, D-O-I-D-G-E. And I was listening to this on a run in Jerusalem, and he was talking about Mike Merzenich this, Mike Merzenich that. And what he had done was he had taken monkeys and the primate studies and given an incision in the brain, caused problems on the left or the right of the monkey, and figured out how to create neuronal regeneration, rewiring essentially in a very controlled experimental fashion, and proved that it was doable. Back when I was in medical school in the dark ages at Tulane in New Orleans, back in the 90s, we were taught as students that the brain could not grow back, that cell death was a done deal. And that's completely false. It's totally antiquated thinking. And so I called Mike Merznick. I finally got him on the phone. He was on a ladder in a vineyard picking grapes. And I guess they were very tall grapes or something. And he's like, look, I don't really have time to talk to you. And I said, look, your website does not include critically ill patients. You talk about all this stuff that you've studied and how we need to rehab the brain, but you have left out one of the most important public health groups in the entire world in your research, and it's a super big deficit, and you need to fix it. And so he got off the ladder, and he said, okay, I'm listening. So that's how I have to get attention of some of these people. I mean, they're so damn smart, but the people are blind to our patients, and they don't think that's real because the data aren't there yet. So anyway, we partnered with Mike Merznick. He has created a company called Brain HQ. Think of Luminosity, but don't, because Luminosity is kind of a big wallet biopsy, and they just got sued for false advertisement, and they're just trying to take, what they're doing is they're advertising for normal people to get better at the product they're selling. But that doesn't change a normal person's life because the normal person's already functioning fine. What we want to do is take diseased people and make them better, which is a whole different situation. So anyway, to bring myself to a close, we partnered with Mike Merznick and Brain HQ. We also went then with Adam Ghazali. He's got a company he's working with called Achille, and they've got a program called EVO, which stands for Evolution. And we right now, in Vanderbilt and in the Nashville VA, we have patients right now every day in their homes, post-ICU, who each have their own iPad, who are doing video games and stuff on the computer, where we can track every keystroke, every second-by-second performance in of their gaming, and we are downloading that information. And the computers are super cool in that they keep the challenge of the game between a 60 and 80% correctness rate. And the reason it does that real time while the person's on the iPad is that if they start performing at less than a 60% correct rate on the game, then they lose hope and they give up and they say, screw it, I'm dumb, I can't do this, I'm out. So it doesn't let them get worse than 60. On the other hand, it doesn't let them get better than 80, because if they get better than 80, they're like losing interest as well. So they have to be kept at a 60 to 80. And I've done this. I've got videos of me playing these games, and it's really challenging. But the beauty of it is that it adjusts to the individual patient, download the information, and then it will adjust itself in real time to keep them between 60 and 80. So this is what we're doing. It's still pilot work. We don't have the final answers. What we eventually want to get to are phase 2 proof of concept studies and then phase 3 randomized controlled trials. That's where we are in 2017. What does this mean for you? What it means for you is that this, and by the way, the data from Merznick and Ghazali show that years later, this is rehabable. In fact, the people that we're proving it works on right now are our brain ICU patients who have been out 6 to 8 years, and it's working. I mean, we've already looked at the raw data. It's totally working. So go back to your hospitals, look at your patients, inform them, teach them, knowledge is power, that they are probably going to have a problem afterwards, not to depress them, but to get them calibrated on where they will be in life. And then do what you can. Charge them up for Sudoku, Scrabble, for something that exercises their brain. Find out what they love. We talked about yesterday. If a person has a reason to live for, a why, they can get by with almost any how. So if the person knows what they need to do, they'll figure out how to get there, but you've got to teach them first. Thank you so much.
Thank you very much, Wes. And the last speaker today, this morning, is Dr. Heidi Engel from UCSF. She'll be talking about what do we do when we don't have all the bells and whistles. Heidi.
Thank you. Okay, my conflict of interest statement. I have in the past been a paid consultant for Arjo Huntley and Craig. I'm not going to sell you any equipment today. And my other note about that is I no longer do either of those jobs, so I guess we're good. 2017 does mark my 30th anniversary as being a physical therapist, so that's 30 years. of my hands on your patients and my eyes in your patients' eyes and my ears listening to what they want and what they need. And so what I'm here for today is to speak to you on their behalf. I am here to tell you what they would say themselves if they were standing here in front of you, their caregivers, right now. And that's a lot of people, 30 years, because I still work a full-time clinical job on top of my academic duties. So I see a lot of patients, and what they want you to know is they want to go for a walk. They don't want to lie in bed and do ankle pumps. They don't want Easton machines attached to their legs. They don't want to be lifted to a chair if they are able to stand up and walk. And if you get to them early enough, they can do it. So after 10 years of really hard work at UCSF, this is what a snapshot of our medical surgical ICU looks like right now. So 78% of our patients will have a PT consultation. We're a large academic teaching hospital, so yes, we have a huge transplant program and we have very sick patients. But 64% of our patients who will receive physical therapy will walk out of their room, so they will walk on their own 2 feet out of the ICU room that they're in. They won't walk 5 feet. They won't walk over from the bed to the chair. They'll walk out of the room as part of their physical therapy session. An additional 10% will achieve a level of standing next to the side of the bed as their highest level of activity. Now, I will say that I do not tell you this as, yay, this is a done deal. We have a lot of people up walking. We are a work in progress. After 10 years, we are still a work in progress as far as I can tell. We still have room to grow. We still have room to improve. We still have the other half of our ICU that also needs to get up and walk around. So you got a lot of work in front of you. And here's what it looks like. So this was a picture I took last week of one of my patients. As you can see, he's on the CRRT and the ventilator. This is a gentleman with an autoimmune disease, ARDS. He got the flu. That's his wife. So we get him up out of bed, and she pulls up a chair into the room. After he's sitting in the chair, she pulls off her shoes, and she makes him touch his foot to her foot as he does his leg lifts. She created this exercise program for him. I had nothing to do with it. But realize when you look at what mobility provides for your patients, it's really a way to treat the entire person, right? It's really not just about keeping the leg muscle strong, although that is really important. It's also about treating all the other things that can happen to a patient as a result of having to be an ICU patient. But if you want to look at the weakness part of it, it has a great preventative effect on ICU-acquired weakness, which we are finding is not really a reversible condition. So ICU-acquired weakness, once your patients have lost a significant amount of their muscle in their legs, it does not come back. Even when the cross-sectional area of the muscle is restored months later as a result of vigorous rehab, that muscle still has lost its architectural and its anabolic process of regrowth so that it can still make a really forceful contraction. So the prevention is going to be our only true answer. Again, treating the whole person, preventing the post-intensive care syndrome. Now, when you look at what is preventing us from getting our patients up and walking around, and there are actually quite a few studies that have done this at this point, the barriers are not really about a lack of a special type of equipment or a lack of a special type of medicine. It's really often about the way we've organized and structured our routines and our attitudes towards our patients and the types of equipment that our patients are attached to. Again, if you look at the flip side, if you look at the research that talks about the facilitators of mobility, it's really just about reorganizing the process of what you do in your day and collaborating with your colleagues. Because we establish the paradigm, we establish the expectations and the culture. When you go to an ICU where the patients know the daily expectation is a daily dose of walking, nobody questions it. It's just a normal part of another thing that you do every day in your ICU, but it's up to us to establish that value system. Once it's in place, it becomes the norm. And that's what you're trying to achieve, because you're making calculated risks on each and every one of our patients. So when you look at the calculated risk, you look at the benefits of what mobility can be. The benefits are huge. The benefits can have a huge impact on returning your patient to normal lives. The deficits are even greater. So by not trying, you're automatically voting for the deficit column, and it is a profound deficit column. If you're not sure if this is really going to work when you go into the room and approach the patient, you try it. You sit them on the edge of the bed, you talk to them, you see how they look, you see how they're responding, you look at the monitor, you look at the lines, you look at the patient over and over and over. If it's not working out very well, if they're suddenly getting tachycardic, if their blood pressure is suddenly dropping, you lie them back down. But I have to tell you, after 30 years, 9 times out of 10, when I walk into a patient's room, and it still happens to me this day, and I think, there is no way this is going to work. This patient is not going to be able to do this. They're too weak. They're too sick. They're too something. I try it anyway. And 9 times out of 10, the patients surprise me. Because as I said, I'm here to tell you what they would tell you. They really want to get out of bed. So again, it's really simply about taking your processes and your culture and figuring out how to rearrange this to do what Polly Bailey at LDS Medical Center in Salt Lake City always says: mobility is as important as the antibiotics that you give to your patient. You would not go into your patient's room and say, you know, if we can get to it today, we're going to give you your antibiotics. You know, if we can't get to it because you got on a CT scan or you've got dialysis or, you know, you're just feeling tired, that's okay. The antibiotics can wait. Would you do that? And it does require a lot of coordination of our team. And our team looks a little different than it traditionally has. So here in the picture, we have our family member. We have our occupational therapist who got the patient out of bed. We have the volunteer who's there trying to engage the patient in an activity that's meaningful for him, trying to do some of the cognitive rehabilitation that Wes was talking about. How does this work? You walk into the room and I say to the nurse, it's time to get the patient up. And the nurse says, great, I've turned the sedation off and they're doing fine. The RT says, yeah, we cleaned out their airway really well. Secretions are cleared. We're good to go. I can come and help you with the ET tubing. We set up the chair. Away we go. Yes, there are a few patients that really and truly are too sick or are attached to something that can't be easily mobilized. But if you look at this list of exclusion criteria, and none of this is a hard and fast rule, most of it, you will see that this is not describing the majority of patients in your ICU. There's only a few people who fall in the can't mobilize today category. But I cannot do the job myself. Sending the physical therapist into the ICU and saying it's really important that we now get our patients up and moving isn't going to cut it. I can't do my job unless the patient's pain has been treated. I can't do my job unless the sedation is turned off. I can't do my job unless we understand how to synchronize the ventilator to the patient and give the patient extra support on the ventilator when they're going to be up moving around. And I should really add to this that delirium assessment has been shown to be a really key to maximizing mobility for your patients in the ICU. That assessing delirium and understanding if your patient is or is not delirious happens to be a key component of helping us to mobilize the patients. So at UCSF, we created a mobility score. It's a 1 to 10 point scale, very simple. It just talks about the highest level of activity that was achieved by the patient that day. And the view we can have of it goes across, can give us a snapshot across every day that the patient has been here or an entire week. If you look at your patient's activity level, it tells you an awful lot about how your patient is recovering or not. If my patient can't get out of bed day after day after day, you need to start asking yourself why. It is a vital sign, mobility. It can tell you a lot about, is this patient ready for extubation? Is this patient so delirious we need to figure out something to fix it? Are we over-sedating this patient? Is this patient so profoundly sick they're not likely to recover? And you need to collect data, because what I see over and over again, including in our own institution, is an optimism bias. And that optimism bias is traditionally applied to us and what we're doing for our patients. And we often will say we have a great early mobility program going. I've heard it in my own institution. Yeah, we get our patients who are vented up all the time. And then I come to the head of critical care and say, I really feel like we're too slow on the vented patients. So what do they say? Prove it. We think we're doing great. You think we could still improve. Collect some data and demonstrate to us. That's really the only way you can tell for sure. Again, mobility treats almost all of the most pressing unmet needs of your patients during their ICU stay. So now it's time for you to get involved in this process. Here's our patient getting up out of bed. He's on a femoral catheter for CRRT, and he's on the vent, obviously. So what I want to ask people is, let's start with some of the typical pieces of equipment that we consider a barrier to walking patients down the hall. Because it is walking that your patients really most want to achieve. Walking is not exercise. Walking is a survival skill that you started doing when you were 1 year old. Nobody taught it to you. Nobody made you go to an exercise class to learn how to do it. You're innately hardwired to walk. It is a survival skill. So who thinks that a ventilated patient should be able to get up and walk? Perfect. How many of you are doing that in your ICU, honestly? Even better. Okay, now let's talk about CRRT. Not femorally cathetered, let's go subclavian. How many of your CRRT patients are getting up and going for a walk? All right, Mr. Strom has it. Perfect. Well, now, let's look at CRRT for just a brief minute, because at UCSF, we walk all our CRRT patients. If you are capable of walking, you will go for a walk. The nephrologist writes the following order in the medical chart. The patient is allowed to be disconnected from CRRT for 2 hours to allow for rehabilitation. Now, you may be saying to yourself, well, what's the point? These people are too sick to get up and walk anyway. That can wait till later. So here's what we found out with mobilizing our CRRT patients by having them get up and walk out of their room. So the nurse disconnects the patient from the CRRT, and then the patient gets up and walks down the hall with the physical therapist. The benefits of the CRRT, what is happening with the CRRT? You're really optimizing that patient's physiology. That same patient out on the floor is a mess before they had to transfer into the ICU and required CRRT. I could not get them up walking at that point because they were delirious, their electrolytes, their fluid, you name it. You know those patients, they can't really move. But now, on the CRRT, their physiology is optimizing. They can go back to walking. If you're leaving them lying in bed, you're now adding harm to a key point in time when they are physiologically getting better. And so what we found when we looked at our case series of our 20 patients who were getting up out of bed and walking down the hall with CRRT, they were achieving higher levels of mobility during their ICU stay while they were on CRRT, all of it engaged in walking, because we took the time to disconnect them for 2 hours in the ICU. Again, all the emphasis on walking is because it is the true activity your patients most need for a lot of reasons. It's a survival skill, but here they are to tell you themselves. So this is my patient who the nurse had gotten up out of bed and put into the chair in the morning, but she was accustomed to going for a walk with physical therapy. She was sitting in the chair for a little while and starting to get a little bit nervous. What happened to the physical therapist today? How come she hasn't been here yet? She wrote in English, her second language, on a clipboard a note and handed it to the nurse and said, please go find the physical therapist. I want to go for a walk. She's not an athlete. She's a sedentary person. She's actually extraordinarily sick. Again, a flu patient in someone with a hematological oncology diagnosis. She knows what she needs best. Now it's our turn to deliver it. Thank you.
Thank you so much, Dr. Engel. We have very little time, but I'd like to invite questions from the audience. Yes, sir. Please identify yourself.
I'm Basant Sharma from Madison, Wisconsin. I have a question about physical therapy involvement in the ICU. Does it affect their annual cap? I know they have an annual cap on how many outpatient visits they get. Is there something that affects inpatient visits they can get in a year?
No.
And is it true for Medicare patients as well?
No. So there are a lot of physical therapy departments that will develop policies about billing and patients not receiving care or capitating care. From an actual billing perspective, that is in no way a barrier. A lot of the barrier is we are not trained to work with people in the intensive care unit. We are not trained to assess them for their mobility needs. That's your main problem. And so we create a lot of rules that make our own barriers. But no, there's not a billing issue.
Okay, thank you.
I think we have time for maybe one or two more questions. Any other questions from the audience? Yes, ma'am.
My question, I'm Charlotte Capini, I'm from Glasgow. My question is, we've managed with some success to get mobilization happening in our ICU and our high dependency units, but when our patients step down to the wards, that's where we really find it difficult to continue that rehab program. And I'm just wondering if you have any suggestions as to how that can be improved.
Go ahead.
So everyone has that same problem. The best thing you can do is to educate your patient. The best success I've had is with educating the patients and the family members, number one, so that they're the ones that actually demand that someone help them get up and walk around when they get out to the floor. And that works really well, actually. The second thing is we created a nursing respiratory therapist collaborative education program that we're doing for both ICU and floor nursing and RTs combined that we run, 3 times a year at UCSF, and we that's the educational piece, staff to staff. But really, it works great when you have, like I showed in the picture, a family member who's really engaged, if you can. I know it's not always possible, but that plus education. I don't know if you guys have something more.
I think also just having good communication in the sign-out. So if the patients, we will often have the clinicians that are in the step-down unit or the regular nursing floor come to the ICU, and then giving them a really thorough and sign-out and mobility, what they were doing day to day, what they were able to achieve day to day is really key. And I agree, talking to the families, so the families they're engaged and they're advocates for their loved ones to say this kind of care really should be continuing. We hope that it will continue. That's our goal throughout it. And don't hesitate to say something if it's not happening.
We've had family members say, we would like to have our patient go back to the ICU so they can get up and move around. And that pretty much takes the floor staff a little bit by surprise.
Yeah.
Okay, I'm getting strong signals that this session has to end. If you have any questions for the panel members, please come to the floor. Thank you very much.
Yeah, it's nice.